Good afternoon, everybody. Today's my topic is on infective endocarditis, and I'll be covering mostly the bacterial endocarditis, that too, bacterial infection, that too, just native wall endocarditis, not the prosthetic wall endocarditis. So, anybody have a brief idea what is endocarditis? Yeah, so it is basically an infection of a endocardial region. So we have three regions of the heart: myocardial, epicardial, and endocardial. So it is mostly the endocardial because it will be affecting by the most of the walls of the like the heart. So heart walls are made of the interior walls, and the tricuspid and bicuspid walls are made up of endocardial muscles. So that's why mostly they are prone to infection. So, and I'm talking about bacterial infection, not the fungi or viral infections over here. Along with it, I'll be covering the native walls, not the prosthetic wall, which patients go through if they have some rheumatic heart disease or birth, or while birth also they have this heart wall defects and all. So this is the overview of the what is infective endocarditis. And when we say infection, we think about any microorganisms to be present. So what other organisms can be present in this infective endocarditis? Basically, we have majorly three organisms which will cause endocarditis. Those are Streptococcus viridans, Streptococcus bovis, and Staphylococcus aureus, and also Enterococcus species. These are all gram-positive organisms which will cause endocarditis. The reason why they are mostly gram-positive is because what happens is in rheumatic heart disease, when the heart wall is defected, when patients go through any dental procedure or for say any invasion procedure for the lungs, for the invasive lung procedure and all, the blood gets infected with the gram-positive organism, which is mostly present on the upper respiratory tract and again in our oral cavity. So, oral cavity and the upper respiratory tract is predominantly occupied by our gram-positive flora. So that's why they will have gram-positive infections. There is also one gram-negative which might cause, that is very rare, that is Pseudomonas species, Pseudomonas aeruginosa, which we know that it will originate from the lungs. So that is one. The less common ones are Staphylococcus epidermis, that is the skin. If they get infected through the skin and the endocarditis occurs due to the from the skin skin flora goes into the bloodstream and it causes endocarditis. So it will be from Staphylococcus epidermis. And also it can be caused due to fungal, that is mostly fungal will be Candida species. So these are the organisms. So okay, organism is covered. Then now clinical presentations. What will be the clinical presentation for infection? We know fever is the topmost. Next, WBC elevations. Okay, we will have fever and a significant weight loss also, because the heart wall is not able to pump properly. So patient will have a significant weight loss, fatigue due to the blood is not transported properly. So fatigue, and again night sweats and arthralgias, muscle pains and all, because the muscles are not getting enough blood to work sufficiently. And also the patient can have conjunctival petechia, that red spots all over the body, and Janeva lesions. Those are also dermatological manifestation. And also splinter hemorrhages, bleeding can occur, basically internal bleeding, that too. And mostly the patient who have this endocarditis will be the mortality is due to mostly congestive heart failure. And next is diagnosis tool. So what will we how will we diagnose a infective patient? What are the parameters we check? WBC. Then we'll check for the culture reports. Culture reports, for other infections we just take one culture report or maximum two we check. But in infective endocarditis we need to check at least 2 to 6 culture reports, that too within a period of time of 24 hours. So that we will get what is the exact organism. Although the organism vegetation will be present in the heart, but it won't be seen in the bloodstream. if you have too much of blood, too much of organisms in the blood, then it is actually a sepsis, not an endocarditis. So it will be present in the blood, but in a very less minute amount. So that's the reason we need 2 to 6 cultures. And again, we use a diagnostic criteria which is called as modified Duke criteria. So it takes into consider of symptoms, this diagnostic approaches, and any history, all of this. And also, AHA guidelines says as golden standard uh, tool to use and diagnose a patient with a infective endocarditis is transesophageal echocardiogram. So that will show us what is the vegetation present, at what position it is present, and again how much is it present. So the endocarditis can be right-sided or the left-sided also, right-sided heart or the left-sided. Mostly left-sided is very fatal and very, that is left-sided is which leads to the cardiac heart failure mostly. Right-sided are very less, and also it is the prognosis is very well actually in this kind of cases. So I'll go with the treatment. Usually the treatment is for 4 to 6 weeks. It's a long time. The reason why it is 4 to 6 weeks, we see other infections, it's mostly like 10, 14 days or, and when we do antibiotic stewardship, we say that it shouldn't exceed a certain period of time. But why in this case we give more than 4 weeks? It's more, right? Like more than 1 month. So 4 to 6 weeks is required because what happens is, okay, I'll use this. So what happens is, first this is our heart, and usually the endocarditis occurs at this region. And it's not that a normal heart wall will have any infections in this region, because like due to the mechanism of like turbulence and all, the blood won't stay over here mostly. It will be present here, not here. Due to the defect in this heart wall, rheumatic heart wall, and it can be of any one. It's not necessary that all the wall cusp should be defected or something. So even if there is a one defect, so what happens is there is an accumulation of blood over here. So this accumulation of blood will serve as a median for the bacterial growth, persistent median of bacterial growth. And again, what happens is when there is accumulation of blood in the heart wall, there is also an accumulation of platelet aggregation and fibrins. So what happens is here, okay, for the blood is there, and also the blood accumulation causes the infection to grow here, the vegetation to grow here, and the platelets will surround the vegetation. And again, over a period of time, what happens is again here also this vegetation shifts here, and it will grow over here. Due to this, platelets and fibrin also will grow around it. So it will form a kind of a biofilm around the bacterial vegetation, so which will cause it to persist for a very longer period of time. And again, due to this platelet and fibrins, it is very hard for most of the antibiotics to penetrate. So due to this reason, mostly the antibiotic regimen is very long, that is 4 to 6 weeks. So I'll start with the antibiotic regimen of native wall endocarditis. This is just for native wall endocarditis. So for the species, and we usually don't start with empirical therapy, we wait for the transesophageal echocardiogram reports, which can be like done very soon, and very fast results will come. Culture reports will come a bit longer, but still they say it is very necessary to wait for the culture report before we start with any antibiotics. So after the culture report is confirmed of Streptococcus viridans and bovis, that too, if the penicillin MIC is at least 0.12 mcg per ml. So this should be the MIC of the organism. for penicillin. So then we start with the penicillin G and ceftriaxone gentamicin. So this is for penicillin susceptible organisms. We start with a 12 to 18 million units every 24 hours. We can give it as a continuous infusion for a continuous 24 hours, or you can divide it into 4 to 6 daily doses. You divide the same thing into 6 daily doses and administer it. And the pediatric dosing will be 2 million units per kg per day. And same, continuous or 4 to 6 divided doses. And again, we can also, instead of penicillin J, we can also give ceftriaxone plus or minus gentamicin. Gentamicin, we should take care whether the patient is having any renal problems also before giving any gentamicin. So ceftriaxone should be given 2 grams OD. We should make sure it's OD, not BID, because OD will give us a proper concentration to be maintained in the bloodstream for a longer duration of time. It can be given IM or IV, and pediatric dosing is 100 mg per kg, that too OD. Gentamicin should be given 3 mg per kg OD. This is also OD to reduce the nephrotoxic effects of the gentamicin. And it can be given IV or IM. For pediatrics, it can be divided into 3 daily doses, depending on the tolerability of the patient. So this is for penicillin susceptible. And this is for penicillin resistant. For penicillin resistant also, we still use penicillin G. But what happens in penicillin resistant, they classify it as is because they have a MIC greater than 0.1 mcg. And the range is 0.1 mcg to 0.5 mcg. When this is the MIC found in the organism, then it is considered as a resistant strain. For that, we have to use the higher dose, that is 24 million units. Same, we continues of 4 to 6 divided doses. And pediatrics should be using more than 2 till 3 million units per kg. And the ceftriaxone and gentamicin, we can use it, but here we don't have an option of minus. We have to add gentamicin with ceftriaxone in resistant patterns. And next is patient who are allergic to penicillin. So if patients are allergic to penicillin, then we should be using vancomycin 30 mg kg every 24 hours IV BD. And maximum is 2 grams, not more than 2 grams should be used. And pediatrics also 40 mg kg in a whole day, BID or TID. So this is for allergic patients. Also allergic patients, in the sense we need to check whether the patient is immediate allergic or the patient has a delayed reaction. If the patient is having immediate allergy, then they are considered as allergic to penicillin. If they have a delayed reaction, then still we can use penicillin and ceftriaxone, but at a slower infusion rate. So that is one criteria for using penicillin. And vancomycin again, vancomycin should be used like according to the ideal body weight. You shouldn't, some patients will be obese, so we shouldn't calculate according to the actual patient's body present body weight, but it should be calculated according to his ideal body weight, not lean body weight, ideal body weight. So because mostly we will consider the whole weight, then the patient can be having a higher dose of vancomycin. If there is a higher dose of vancomycin, it can lead to the patient to get a red man syndrome, which is a typical ADR of vancomycin. And again, if the vancomycin is infused very fast, it should be infused for 1 hour at least. So that will help us to avoid red man syndrome caused due to the vancomycin. And the next common organism we find is Coagulous positive staphylococcus. Coagulous positive staphylococcus. Again, this regimen we use naphthalene, oxacillin plus or minus gentamicin. Naphthalene we use 2 grams IV every 6 hours. For pediatrics 150 to 200. And for oxacillin is also the same dose, 2 grams, but pediatrics should be given 200 mg per kg per 24 hours. And the duration of the treatment is 4 to 6 weeks. Here the duration is 4 weeks. Gentamicin should be continued for 2 weeks. And if the MIC is high, like this is 0.1, 0.5, then it should be continued for 4 weeks actually. Gentamicin and ceftriaxone also. 2 weeks, 2 weeks is not usually recommended. And again, vancomycin also 4 weeks. So here 4 to 6 weeks. It depends on the patient's tolerability to the antibiotics again. So, but mostly it should be at least for 4 weeks. Then again, gentamicin 3 mg kg per IV, TID or OD. You can give a OD or TID depending on the patient's tolerability. Then this is for susceptible, penicillin susceptible organisms. And this we have for penicillin resistant. So penicillin resistant, the general guidelines is to use cefazolin plus or minus gentamicin. Cefazolin should be used 2 grams IV for every 4 hours. No, sorry, 4, 3. It should be used for every 8 hours, 8 hourly. So every 8 hourly, cefazolin plus or minus gentamicin, and gentamicin also every 8 hourly TID, 100 mg per kg per 24 hours, 4 to 6 weeks of the duration should be used. And this is for again our penicillin allergic. We can use vancomycin for penicillin resistant also, and for penicillin allergic also vancomycin, the regular dose, that is that 30 mg per kg, and for the pediatrics 40 mg per kg. The same dose can be used for this strain of the organism also. Then we have enterococci and streptoviridians. Why did I write streptoviridians again is that the reason being here, this streptoviridian species has a MIC more than 0.5. So here we had a MIC of around 0.5, 0.1 to 0.5. Here the patient is having a streptococcal viridian with MIC more than 0.5 mcg. So in this case scenario, we have to use penicillin G with gentamicin. The range is 18 to 30 million units, and for the pediatric it is must 3 million units. There we have 2 million units mostly. So here 3 million units is must, and it should be continued for 4 to 6 weeks. And gentamicin is again same, 1 mg per kg every 8 hours for both pediatrics and adult patients. And also, or we can also use ampicillin plus gentamicin. Ampicillin plus gentamicin. Ampicillin dose should be adult 12 grams divided into 2 or 6 daily doses, and or it can be given as a continuous also with the gentamicin. It is important that for enterococci species we add gentamicin for all the regimens, whether you use penicillin G, ampicillin G, or vancomycin C. Vancomycin, and vancomycin is mostly used for penicillin allergic patients. That's all. The dose is similar, and it should be, and for enterococci species who are resistant or allergic to the penicillin, vancomycin plus gentamicin dose, regimen should be used for at least 6 weeks. It is best prescribed for 6 weeks. And usually when we are giving gentamicin with any other penicillin, we should make sure that the patient is having a normal renal function, and also it is not very much prescribed for more than the age of 65 years old, because we know that the renal function decreases after the 65 years of age, like usually in the elderly patients. And also gentamicin should be given mostly preferred OD to decrease its nephrotoxic nature. And also it is necessary for us to check for the renal adjustment of vancomycin and gentamicin, both of it. So as a pharmacist, we need to be sure that gentamicin dose is correct according to the renal creatinine clearance. And also vancomycin, we should give the dose according to their ideal body weight, not the actual body weight. And also gentamicin is not prescribed when the patient is having any heart abscess in his heart walls. There is any abscess, this can cause more aggregation of his symptoms and thereby leading to congestive heart failure. So it's best that we check for any, first is renal impairment, their ideal body weight, and also the nature of the disease, nature of the, no, sorry, what is the species which is causing the infection. And we need to make sure the duration. Duration is very important because it will help for the better prognosis of the patient. That's all.